Ladies and gentlemen, please take your seats. Our program will begin shortly. Ladies and gentlemen, please take your seats. Our program will begin in 5 minutes. Ladies and gentlemen, please take your seats. Our program will begin in 5 minutes. Ladies and gentlemen, please take your seats. Our program is about to begin. Ladies and gentlemen, our program will now begin. At this time, ladies and gentlemen, please welcome. Ladies and gentlemen, please welcome Libby Hoy, Patient and Family Representative.
Should I go? Good morning and welcome to the 2018 Quality Conference. My name is Libby Hoy. I'm the founder and CEO of PFCC Partners. When I was a teenager, my mom was diagnosed with breast cancer. 3 years after, and I became a family caregiver in those moments. 3 years after her death, I became a mom. I have 3 amazing sons who live with mitochondrial disease. Through that journey over the last 25 years, we've experienced 31 surgeries in 13 different hospitals across the country. We've had hundreds of PT sessions, outpatient visits, inpatient visits, all the way across the country in large academic centers and in rural organizations, rural hospitals in the Sierra Mountains and in Puerto Rico. Last year, I was diagnosed with stage 3 salivary gland cancer and endured significant surgery and concurrent chemo and radiation. Those are the credentials I have to stand before you today, that of a patient, of a family caregiver. Throughout our journey, we've been challenged. We've had access issues, we've been harmed by medical error, and we've encountered some dehumanizing circumstances. but we've also been really empowered in the healthcare system to be a full participant of our healthcare team. We've been activated to support management of our care and coordination. And through this team-based approach, we've developed some really tremendous outcomes. Case in point, I'm here today. Thank you. There are many of us attending the 2018 Quality Conference, patients and family caregivers who are eager to share their lived experience in the healthcare system to inform your efforts to improve it. Imagine the oceans of knowledge we have together in this room. I truly believe that patients and families are the most underutilized resource in the healthcare environment for improvement. Cynicism's so easy, isn't it? And there's way too much of it in our world today. But you and I didn't come to Baltimore to be cynical, did we? We came to be aspirational in our aim to together improve and develop and co-design a high-quality, safer healthcare system. We came to learn and to grow, to activate each other, to create the system that nurtures and respects every soul who enters it. What I've learned on this crazy journey of ours is that there are a lot of really good people trying to do the right thing for patients and families in a system that sometimes restricts them from doing so. What an opportunity we have together to improve that system. So this is my commitment to you, this week and following, to be your partner, to help you design structures in your organization so that you can engage your patient and family populations as an active strategy to co-designing a high-quality and safer healthcare system for all Americans. Thank you.
Ladies and gentlemen, please welcome to the stage Dennis Wagner, Director of the Quality Improvement and Innovation Group, Center for Clinical Standards and Quality; Janine Iwago, Deputy Director of the Quality Improvement and Innovation Group; and Dr. Paul McGann, Chief Medical Officer for Quality Improvement.
Thank you, Libby. That was really the best way to start this conference. We are all here because of the tremendous work that we do to improve healthcare quality for our patients. And we thought the best way to start this was with a patient. So I want to thank everyone for being here, and I want to give a round of applause to all of our patients, family members, and advocates. Woo! So the first thing we want to talk about is who's in the room. So we know our patients, our advocates are here. We have a whole host of quality improvement networks, private partners, federal partners, regional partners, our Office of Acquisitions and Grants Management. Everyone is here. There's 2,500 people registered for the conference this year. This is the biggest conference that we've had thus far, and believe me, organizing this is like planning a wedding every single year. So, you know, it's not a wedding unless you have a little bit of drama beforehand, but we're all here. I'm happy to see everyone. And I also just want to say that before we got here, I tried to walk around and say hello to each and every one of you, but I'm sorry if I didn't make it to you, so I'm saying welcome, welcome, welcome now to everyone. And I'm so happy that you guys decided to join us. Over the next 3 days, we're going to be working to align with the new key priorities that our administration has set. We are working to reduce the opioid crisis, reduce burden, align our work with the CMS meaningful measures, and we are going to be constantly learning from each other. We're going to be both teaching, sharing, and learning. I walk away from this conference every year with renewed motivation, new thoughts, a whole list of new things that I'm going to do differently this year, notes of things that I'm going to go back and learn more about, and then also, I also always have a long list of commitments that I've made. And so I want to make sure that all of you are in that mindset as we welcome you to this year's 2018 Quality Conference. So we're going to talk, we've already heard from Libby why she's here. Each of us are going to talk a little bit about why we're here. And this slide shows my purpose for being here and being a part of the Quality Improvement Network. I've worked with this work for about 9 years at this point. And it's become part of I used to say work-life balance, but now I say work-life harmony. Because everything that I do at work, I know is going to benefit me, it's going to benefit you, and it's going to benefit my family. And so it's all mixed up together for me. This is Axel, Levi, my Uncle Marty, and then Levi, Uncle Marty's 80th birthday party. So how does this impact my life? Really, I am working to make sure that when we enter the healthcare system, and we don't know when that's going to happen, but we do know it is going to happen. When we enter the healthcare system, that we receive healthcare that is safe, that is the accurate healthcare that we actually need, and we want to walk away from that situation unharmed and feeling as though we made the best decision for ourselves. And so, thank you. I hear one of my patient advocates out there. So, in order for us to do that, we have to be resilient. This is not going to be easy. This is not about setting goals that we think we can incrementally set in 2, 3, 4, 5 years. This is about creating a healthcare system, setting goals that are exactly what we want for ourselves, and that's exactly what we want for our patients. And so those are really moonshot goals. This is not, I think if I do this, we'll get there. This is, what do I want? That's what I'm going to strive for. And that's my purpose in working for healthcare quality improvement, setting those bold goals for myself and for my family, and then for my future, because ultimately this is going to impact me. And so I want, the reason why I have a picture of my Uncle Marty, so this picture was taken at his 80th surprise birthday party. And not every 80-year-old can have a surprise birthday party. But Uncle Marty is a Vietnam veteran. He is a traveler. I think he had like the best Christmas ever. I learned how to bake a turkey, and he sent me a postcard from Hawaii saying, Merry Christmas. So I want to be like him. I want to be healthy. I want to be vibrant. I want to be spicy, and at my 80th birthday, I want to be surprised to have a big party and walk in and pick up someone else's 2-year-old. Thank you.
All right. So welcome, everyone. My name is Paul McGann, and Janine just kind of reviewed a lot of the goals that we're going to have for the future. And she talked about commitment, she talked about action, and she talked about work. So I'm here to talk about the work. Now, if you read her slide carefully, she also said fun, and I believe work can be fun. So we have a slide here, and we don't have much time, so there's 7 things on this slide, but as we were preparing for this session, we were saying what has to be done in the next few years isn't 7 things, it's 37 things. But we wanted to list these 7 just to give you a taste, and the rest of the 3 days we're going to be talking about those other 30. And at the top of the list, you can see 2 items that have to do with what Libby Hoy was talking about. And that is bringing patients and families more into our work and actually taking a consumer-oriented approach to healthcare quality improvement. Putting the consumer in the driver's seat, giving the consumer the information they need, being more transparent about how our system works. We think those are 2 of the most important jobs that are facing us. We also want to, of course, continue with QPP and providing technical assistance to every clinician that's in QPP. We want to encourage the production of more clinicians into alternative payment models. We want to ramp out the outcome and cost savings results from the TCPI project. We're very, very interested in chronic kidney disease and end-stage renal disease, preventing progression to dialysis, but as well, when ESRD comes, ensuring that all of our patients know about transplantation and have access to transplantation. We have a lot of innovative ideas about that. Woo! We want to continue our journey to reduce the all-cause harm rate in America's 5,000 hospitals to 0, if that's possible. And our new bold goal is a 20% reduction in U.S. All-cause patient harm by 2019. And since it's 2018, that's by next year. So that is a bold goal. And then finally on this list, sustaining and expanding momentum in the nursing home quality project. You know, I started at CMS 15 years ago in the nursing home quality arena, and we've made just tremendous advances, reducing the use of antipsychotic agents, reducing pressure ulcers in that setting, and we want to build on the successes that we've accumulated to date. Now, as Janine said, there's somewhere between 2,500 and 2,600 people registered for this conference this year. And we've talked many times in past conferences about how the world turns. And we believe one of the things that makes the world turn are requests and offers. And so just imagine if every one of you in this room would do over the next 3 days, say 5 commitments each. That would result in 13,000 commitments by the end of the day on Wednesday this week. And for overachievers, if you could do 10 commitments, that would result in 26,000 commitments. So we're asking you to think about that, see what you can do, and start making commitments, just like Libby Hoy did when she stood up here a few minutes ago and made her commitment to you. The other things we want to ask of you, and this is a request right now, is to embrace change. You know, the healthcare system is changing rapidly, the payment systems are changing rapidly. A lot of people and a lot of our fellow clinicians are suffering because of it. But embrace the change and move toward the change. Seek out innovation, new experiences, and new partnerships in the 3 days here at the conference, and try to think about data differently. We're going to have several sessions where we talk about the importance of data as a marker of our progress to improve quality. Now, why am I doing what I'm doing? Quite literally, the reason I'm here is because of the woman you see on the screen here. This is Dr. Marlene Gilliland. She's my mother, and she's 89 years old. And that's a recent picture of her. In the middle, she's standing in front of the golf course that she lives on. She's 89 and she plays at least 9 holes, often 18 holes of golf every single day in Southern California. This is the ideal of aging we should aim for in this country, for every member of our country and every population in our country. My mother embraces change. She's a retired nurse practitioner, and a retired PhD. And about 3 months ago, she called me up on the phone and she said, I need to take another trip. And the other 2 pictures you see there, I said, oh, that's great, Mom. I thought, you know, where is she going, on another Caribbean cruise or something? She said, I'm flying to Dubai. And I said, well, how long does that take? And she says, it's a 19-hour flight. But I'll be just fine, don't worry about me. And the 2 pictures there were taken of my mother in Dubai just a few months ago. She's the first person in our family to ride in a self-driving car all around Dubai. So imitate my mother and embrace change and go for it during the conference. Thank you.
All right. So we've got a great team. And it's a big team. It's all of us in this room. And you know, one of the extraordinary things about the team that we have in this room is we've got a culture. We've got a way of working together. We have a way of working with each other that I think is phenomenal. It makes, for all of us, our work to be vibrant, engaged communities of action, working to support healthcare providers across the United States. Now, my aim here this morning is to make an additional request of you for how we be during the course of this conference. And this is not new language. Like, this is something that we talk about all the time in our networks. I was in a session this morning with Dr. McGann and Jade Perdue, and we were talking about how the hospital improvement innovation networks want to be over the course of the next 3 days. So my request for you, and this is a product of the work of our team, is that we be together these 3 days, the things that you see on this slide, focused on the patients we serve. It's no accident that Libby Hoy, representing patients, came first in this conference. That is the mantra, that is the way we want to live out our work, is putting patients at the foreground. We do this work for them. Aligning with new goals, renewing and committing to aims, engaged and contributing, open, solution-seeking, authentic, and in action, as you've heard, making requests and offers so we can get to the 26,000 commitments that Dr. McGann was talking about. It really is that, right? It's making requests and offers that generate commitments, that generate actions, that generate results that cause the world to turn. That is the work that we get to do every single day together as a community of practice. Now, this being thing is important. Like, the default is how I feel, like how I feel on any given day, in any given meeting, in any given session or conference. What we're asking all of us to do here together is to be a certain way so that we drive things forward, that we make things better. Now, I'm sure some of you have ways that you intend to be that aren't on this list, and I just invite you to kind of make a mental note right now about the way you want to be during the course of this conference in addition to what you see here on this list. Now, I would like to have sort of a collective head nod here. Can we do this? Are we willing to kind of engage and be this way together? All right, this will make all the difference in our work. What we think is a choice. What we say is a choice. What we do is a choice. These are choices that we're living and acting out every single minute of every single day at this conference, back home, in our work, and in our lives. And when we think about things that move us forward, when we say things that will help other people, and we make commitments, that makes all the difference. It's what makes this work fun. It's what makes this work rewarding. It's what makes this work impactful and meaningful for the patients that we serve. Now, following in the tradition of my two colleagues, Janine Nwugo and Dr. McGann, I often like to talk about the work. There's no question. I'm a results, work-focused person. But I'm learning from my colleagues and from Jean Moody-Williams and others that you got to kind of put yourself out there, right? Be a little bit vulnerable. And so I want to share with you a little bit. I had an extraordinary experience with my family last summer. We hiked 500 miles in 34 days, rain or shine, hot or cold, wind or wet, every single day, on what's called the Camino de Santiago. So this is a Catholic pilgrimage that was begun in the 800s by Charlemagne, the King of France at the time. And pilgrims have been hiking from France over the Pyrenees Mountains across Spain to the coast to the Cathedral of St. James since like 840. That long, pilgrims have been doing this. And my family and I decided that we wanted to do this together this year. And we were doing it to strengthen the bonds of our family and to strengthen our faith in each other and in humanity. Like, that's what it was all about. My wife and I started out together in Saint-Jean-Pied-de-Port in France, and we walked the whole 34 days together. Now, I don't know how many of you have spent 34 days, like all day long, every meal, all night long, every night with your wife or your spouse. So if you're interested in a marriage encounter, try the Camino de Santiago. Now, our kids joined us along the way. You see their picture in the lower right-hand corner. Tess, she's 22, Grant, he's 19, and Margot's 16. So they kind of joined us, at day 18 and day 21, that kind of thing. And we finished together. And I was all about the destination. I wanted to get to the cathedral, right? So this is the Cathedral of St. James. That's the destination. You see the 5 of us laying on the plaza, thumbs up. Right? So we made it to the destination. But we learned a lot along the way. I learned a lot along the way that I kind of knew before I went, but I knew it in a different way when I came back. And I think some of the things that I learned on this pilgrimage are highly relevant to the work that we get to do together every single day. So aims create systems, and systems create results. You hear us say that all the time. It's the God's honest truth. If your destination is that cathedral and you start 500 miles away, you create all sorts of systems to get there. Most of them involve your feet, like preventing blisters, treating blisters, preventing and helping other people treat blisters, right? I sent a list of my PDSAs back to Kayla Reynolds. I had 9 PDSAs. She said, how do you mention the word blister 11 times in 9 PDSAs? But we got there, and we created systems along the way to get there. It was really quite rewarding. The other thing I learned, I'm kind of a destination person. Like, I was focused on the destination. I'm focused on the results at work. But we all know the journey is every bit as important or even more important than the destination. And you know, we have a great journey together here. Like, we get to work with people like Libby Hoy. We get to work with people like Janina Wugo and Dr. Paul McGann and each other. I look forward to this conference every single year because it's a collection of some of the most talented, committed, interesting, exciting people on the planet. And the journey that we get to take together is exceptional. It's an exceptional journey. So I would say, savor every moment of it. Like, I learned that on the Camino, and I'm learning it every single day since then. The last lesson is that we're all in this together, and we need to help each other. And that relates to my commitment. So my commitment to you is that as we go forward in this work together, you will see from our team and from our group a team that is seeking to generate joy, that is seeking to help each other in ways that are good, that have respect and civility and celebration and cowbell ringing as part of it, because we want your journey and your destination to be great. Thank you, and welcome to the 2018 CMS Quality Conference.
And now, please welcome Dr. Kate Goodrich, CMS Medical Officer and Director of the Center for Clinical Standards and Quality Center for Clinical Standards and Quality.
Good morning, everybody. I have been looking forward to this day for weeks now, and I do every single year. It is so wonderful to be with you here today. I want to give a special welcome to the patients and families who are with us here today. You're critical to our work. We couldn't do it without you. We couldn't get the results that we have seen without you, so thank you very, very much. So it is my distinct pleasure today to introduce to you our next speaker. Seema Verma was sworn in as the 15th administrator of the Centers for Medicare and Medicaid Services on March 14th of 2017. She brings deep experience in healthcare policy, Medicaid, insurance, and public health to her role at CMS. Administrator Verma completed a master's degree in public health with a concentration in health policy and management from Johns Hopkins University and a bachelor's degree in life sciences from the University of Maryland, so she's a local. Previously, she was the president, CEO, and founder of SVC Incorporated, a national health policy consulting company. Continuing her efforts to improve health outcomes for all Americans, Administrator Verma is working toward a new era of state flexibility and local leadership at CMS. She aims to reduce burdensome regulations so that doctors and providers can focus on providing high-quality health care to patients at lower costs. And much of what we and you will be focusing on during this year's Quality Conference is a direct result of Seema's priorities that she's laid out over the last year. Seema is relentlessly focused on getting results and holding ourselves collectively accountable for better patient outcomes at lower costs. On a personal note, I just want to say what a joy it has been to work with Seema over this last year. She is absolutely committed to putting patients first, and I can tell you that every policy conversation that I've been in on with Seema is firmly centered around that goal. Seema, thank you for your leadership and direction over this past year, and everybody please give Administrator Verma a warm welcome to the CMS Quality Conference.
Good morning, and thank you, Kate, for that kind introduction. You've truly been a great partner, and I've been so appreciative of your leadership. You've been willing to move in new directions in our transformative work to advance quality care, and CMS is very lucky to have you on the team. So since we've come into office, we have been working to put patients first. And we set forth to accomplish 4 main goals at CMS. First, improving the customer experience. Second, ushering in an era of state flexibility and local leadership. And third, supporting innovative approaches to improving quality, accessibility, and affordability. And fourth, empowering patients and doctors to make decisions about their health care. In so many ways, the work that all of you do every day is helping us to fulfill our goals. And that's why it's an honor to kick off the CMS Quality Conference and to thank you for joining us at this always anticipated event. And I'm especially pleased to welcome the patients and family members who are here this morning. Your involvement brings urgency to our work, your experience gives us direction, and your perspectives and contributions are truly valued. And finally, I want to thank our CMS employees, the state Medicaid quality champions, and our many quality networks for the extraordinary difference you're making. Your successes are notable. You're supporting quality efforts in 12,000 of our nation's nursing homes, 4,000 hospitals, 400 community coalitions, and more than 500,000 providers in every state. The results speak for themselves. For example, quality efforts by one hypertension control network reduced hospital readmissions by 45% and saved over $33 million. The Hospital Improvement Network recruited the 4,000 hospitals I just mentioned to accept the challenge of reducing harm by 20% and readmissions by 12%. And 18 end-stage renal disease networks produced an almost 42% national reduction in bloodstream infections. This all deserves a round of applause. These are just a few of the outstanding examples of our shared work to improve quality and safety for patients. I'm proud and grateful for what's been accomplished, but I also know that there's still so much more to do. We must build on, not rest on, the extraordinary steps you've already taken. And today I want to discuss with you what CMS is doing to support quality care. This includes patients over paperwork to reduce burden, the Medicaid scorecard, the hospital star rating system, and our response to the opioid epidemic that our nation is facing. CMS's Patient Over Paperwork initiative is part of President Trump's Cut the Red Tape initiative, which directs all federal agencies to take steps to reduce regulatory burden. In healthcare, we understand that regulations play an important role in ensuring quality, integrity, and safety of the system. But there can be a fine line between being helpful and being a hindrance, between regulatory benefit and regulatory burden. It's no surprise to me that on my national listening tour, a Connecticut provider said that she was going to close her practice after decades in medicine. She said she simply couldn't keep up with all of the regulations and requirements. And her comment echoed so many others throughout the country. Unfortunately, we now have a system where providers are spending more and more time away from patients. CMS alone publishes nearly 11,000 pages of regulation every year. We need doctors and nurses on the front lines treating patients and not filling out forms and checking boxes. According to the American Hospital Association, 15 doctors and nurses are needed per hospital for compliance, and regulatory burden costs $1,200 every time a patient is admitted to a hospital. Additionally, $39 billion is spent by health systems, hospitals, and post-acute care providers each year on non-clinical regulatory requirements. It's no wonder that in all of the conversations I've had this past year, regulatory and administrative burden is always a top priority for providers. Well, we've not only listened, we heard. And that's why we launched patients over paperwork several months ago. As many of you are aware, it's an agency-wide initiative that's examining our regulations with the goal of cutting burden across the board. Last year, we put out requests for comments in all of our payment rules so we could hear from providers about how our regulations can be improved. We are also asking CMS employees to go on site to healthcare facilities so they can understand how the rules they write impact day-to-day operations. And we're also developing journey maps so we can understand how all of our regulations collectively are impacting the delivery of healthcare on the front lines. And one of the areas that we heard about across the healthcare delivery system in every RFI were concerns about quality measures. We all understand the importance of quality, whether we're buying something on Amazon or placing a loved one in a nursing home. We want the best. We want to know what we're getting. And when patients enter the healthcare system, they also want to be assured that they're receiving quality care. And CMS has an obligation to assure quality for all. Quality measures are also critical as we move away from a fee-for-service system to a system that pays for value. And let me be clear, moving away from fee-for-service is something that Secretary Azar and I are committed to. And ensuring quality is an essential component of this. We want to support quality, but there have been unintended negative consequences of too many quality measures. When a provider has to spend more time looking at a screen than engaging with a patient, or spend more time reporting data than actually providing care, then we're collecting measures at the expense of patients. When there are too many measures, or measures are too complex, then we're actually creating roadblocks to quality care. We need reasonable, practical approaches to quality measurement. And that's why CMS announced our Meaningful Measures initiative. Like everything we do, Meaningful Measures starts with the patient at the center. CMS measures must now meet one of our designated criteria. They include eliminating disparities, tracking to measurable outcomes and impact, not process, safeguarding public health, for example, with quality measures for preventing opioid addiction, achieving cost savings, and improving access for communities. The criteria were created after considering what will have the greatest positive impact, and among other things, they'll help ensure that we have the right measurements, that they are meaningful to patients and providers, that we're measuring outcomes and not processes, that the measures are easily reportable, and that they are consistent and aligned across settings and programs as appropriate. We need to focus on the most important areas, as we know that we can't do everything at once. And ultimately, we need to get to a system that can extract data without clinician effort through EHRs, registries, or claims data. We're committed to measuring quality without increasing burden. For CMS, this is not just talk. What you'll already see across the board are new measures, less measures, and more focused measures in all of our programs. So consider some of the results so far. We've removed a number of hospital quality measures, and this resulted in an estimated burden reduction of almost 500,000 provider hours, ensuring that doctors have more time for patients. It also saved $16 million. Additionally, thanks to changes in home health quality reporting, we estimate an annual burden reduction of more than $145 million, and the burden on home health clinicians was reduced by 2 million hours annually. But this is just the beginning, and as CMS develops the next quality improvement organization plan, we will focus on meaningful outcomes, as well as flexibility and easing provider burden. We look forward to reviewing and considering your comments and ideas, and we hope that you will continue to work with us and to partner with us. And of course, it's not just Medicare. We're also looking to advance quality with our brand new Medicaid scorecard. As I've said, CMS is committed to ushering in a new era of state flexibility. But with that flexibility, we must also advance a new era of transparency and accountability in the federal-state Medicaid partnership. To support that partnership, CMS has developed the Scorecard Initiative to provide greater public transparency for the Medicaid and CHIP programs. Under this effort, we want to bring all of your success, all the ground that you've already covered, to the Medicaid program. This will help ensure that the nation's most vulnerable populations have access to high-quality care and that we're delivering on our promises. The scorecard includes federal and state reported measures in 3 areas: state performance, such as outcomes of postpartum care or well child visits; state administrative accountability, such as state timeliness to responding to certain requests from clients; and CMS accountability. For example, we will track how long it takes for CMS to approve waiver applications. To develop the first iteration of the scorecard, we worked with Medicaid agencies across the country, and we're beginning with measures that we're already capturing before adding any new administrative requirements. We plan to release the first scorecard this year, and as the quality experts, would love to get your input on it. Our objective is to have alignment of measures across programs so that providers have consistent goals. As we work to advance our new Medicaid scorecard, we've also recently updated our hospital star ratings. We wanted to include several improvements to the methodology, which were suggested by experts and external stakeholders. The improvements significantly enhance the reliability and the accuracy of the ratings. And of course, our work is far from over. We know that there is a lot more to do. We're continuing to receive feedback from hospitals and patients and others on the star ratings, and we're actively working on additional enhancements. Amongst these, we're looking at making peer group comparisons. For example, we want to compare similar hospitals, such as surgical specialty hospitals, to one another. And we're also examining ways to take into account the socioeconomic status of patients that a hospital serves. This is an issue that I hear about with many of our measures. We look forward to your input as we continue to improve our metrics. And as we continue to work on our hospital star ratings, we're also looking at opioids. As you know, the Health and Human Services has declared the opioid epidemic a public health emergency, as this epidemic is devastating too many of our communities. Overdoses are now the leading cause of death for adults under 50. The Trump administration has made this a top priority, and at CMS, we are looking at how we can mobilize resources and efforts across the agency to focus on addressing the epidemic, and our efforts in quality will also play an important role. CMS has now added opioid use disorders as a key meaningful measure area. We've also included other opioid-related quality measures in our yearly Measures Under Consideration list. And as you may be aware, this list lets the public know which measures we're considering for the Medicare program. Additionally, we've included opioid-related measures and clinical improvement activities into Medicare's quality payment program for providers. And finally, CMS is working with the National Coordinator for Health Information Technology to incorporate opioid-related quality measures into electronic health records. While today I have outlined some of our accomplishments on opioids and Medicaid, this year you will see even more from us on our efforts to implement meaningful measures and patience over paperwork. These efforts will be reflected in our payment rules and will impact providers across the healthcare delivery system. It will demonstrate our commitment to quality and reducing provider burden. And of course, as we move forward with all of our initiatives, we really need to hear from the people on the front lines, people like yourselves. At CMS, we know that we can never fulfill any of our goals and so ensure that we're putting patients first if we work in isolation. We need the engagement of all of our partners here today. We need your ideas and input. We need the benefit of your expertise and experience. And we need to listen to you and to learn from you and to be challenged by you. I promise that this will always be a partnership, a dialogue. This won't be Washington simply telling you what to do. Working together, I know we can always put the patient first. It's been a great pleasure to join you this morning. CMS is grateful for all that you're doing to improve quality and healthcare throughout our nation, in every community and every forgotten corner. Undeniably, the safety and quality of health is important, and the Americans are across communities across the nation are better for your efforts. I wish you a very successful meeting, and thank you.
Ladies and gentlemen, please welcome Debbie Hattery, Deputy Director, Center for Clinical Standards and Equality.
Thank you, Administrator Verma. I have the great pleasure this morning of introducing Kim Brandt. Kim Brandt is the Principal Deputy Administrator for operations at the Center for Medicare and Medicaid Services. She supports the administrator in all activities that are necessary for the operations and management of the organization. And in addition, assists the administrator with implementation of many of the priorities that you just heard the administrator mention. But most importantly for our next session, Kim is the executive leading the efforts at the agency around combating the opioid epidemic. So she's a very busy woman and does it with great humor and great judgment and great leadership. So a little bit about her before she came to the CMS. She served as the Chief Oversight Counsel on the majority staff in the U.S. Senate, on the U.S. Senate Finance Committee, where she has served on the committee staff from January, make sure I can see what I'm saying here, January 2011 until last August 2017, which is the time at which she came to CMS. In her role on the committee, Kim coordinated oversight of the whole range of committee issues, including tax, healthcare, Social Security, and trade. But before joining the Finance Committee, she was senior counsel at the Alston & Bird in Washington, D.C., advising clients on healthcare compliance and fraud and abuse issues. Her previous government service includes serving for 7 years at CMS as director of the Medicare Program Integrity Group, so she knows a lot about our agency, how we work, and how we operate. Prior to her first tenure at CMS, Kim worked for 5 years at the HHS Office of Inspector General as special counsel and director of external affairs. Kim received her JD with a concentration in health law from the DePaul School of Law, a master's in legislative affairs and health policy from George Washington University, and her bachelor's from Valparaiso University. She is a nationally recognized expert in healthcare, compliance and fraud and abuse issues, and in 2016 received the prestigious Healthcare Compliance and Ethics Professional of the Year Award from the Society for Corporate Compliance and Ethics and Healthcare Compliance Association. So you can see she is a very busy and accomplished woman. We are very, very proud and happy to have her in our leadership at CMS. And on a personal note, you should know about her in case you run into her as she's leaving here. She has a dog named Sherlock, and the last picture of which I saw with a big red ribbon around his neck on a wagon. But I understand that if you go to her Facebook page, you will learn lots about Sherlock and about Kim's love of her dog. We all know about that, and again, appreciate very much the leadership that she has brought to our agency. So, Kim Brandt.
Thank you. Good morning, everyone. Nice gray day here today. So let's go ahead and see if we can get my slides up. There we go. So as Debbie mentioned, and as the administrator indicated, the opioid epidemic has been a huge issue for this country. And I know you were expecting to hear from the Surgeon General today, and you got me instead. But I'm hoping to still give you a little bit of an overview of what we're doing at CMS to combat that epidemic, and then look forward to joining the panel after this, where we'll get into that in a little more detail. But at CMS in particular, this has been one of the administrator's top priorities, and is certainly a top priority of the administration. For those of you that have heard him speak in his 2 weeks that he's been here, the new secretary, Alex Azar, has made opioids one of his top 4 priorities. He's made it very clear it's something that he's going to continue to focus on, and he wants the rest of HHS to continue to focus on as well. So to that end, the administrator has tasked me to work with all of the components across the agency to really come up with a comprehensive roadmap of what we're going to do and how we're going to work together to really begin to look at this issue from our position as a payer. CMS is unique because we are the world's largest health insurer. As such, we impact the lives of over 130 million people across the CMS programs. And that means that the opioid epidemic is a particularly big issue for us because so many of those people are older adults or dual eligible individuals, which causes a lot of unique challenges for us in the system. So what I've been doing over the past few months is working with all the components across the CMS range to really begin to see what everybody's doing and how we can pull all that together to create a comprehensive roadmap that will help us to be able to figure out how we can start to move the dial a little bit in terms of how the opioid epidemic is impacting the individuals that we cover through Medicare, Medicaid, and the exchanges. The first step that we took on this was last fall. We had a series of 4 listening sessions with industry. We met with other plans, so other big payers who cover a lot of lives in the commercial sector, as well as Part D and the Medicare Advantage program. Then we had a second session where we kind of dealt with the downstream entities, if you will, the supply chain. So we met with PBMs, we met with group purchasing organizations, we met with some of the big retailers in the pharmacy world like Walgreens, CVS, and Rite Aid. Then we met with the states. We had 12 of the states that were the most impacted by the opioid epidemic in terms of having the largest number of lives lost or the largest saturation of opioid issues in their state, and really had a good discussion with them about their challenges, what they were seeing, and sort of what difference they were making with the types of programs they were initiating. And then lastly, we met with the providers directly. So we had a lot of provider groups in from across the range, from doctors to psychiatrists to others who were involved in these issues from various perspectives on the provider side. And from each of those sessions, we had certain themes that emerged. And we took that along with the wide range of activities that was already ongoing at CMS and brought it together to really begin to form the basis of the roadmap that we hope to issue later this month. But the things that we talked about at those listening sessions and the types of activities that were ongoing really go into 3 buckets that you'll see up on the screen. And those were prevention activities, where there were a lot of different things in terms of how we can stop before people even get addicted in the opioid setting. What can we do in terms of alternatives to get them so that they don't ever get on opioids to begin with? How can we work with them on alternative treatments or therapies so that they don't have to go there? Then we also talked about treatment itself. Once they are getting treatment, what are the different types of modalities that can be used? Are there alternatives such as acupuncture or other types of things that could help them as they work at the treatment? And then lastly, data. One of the biggest things that I have found, and the administrator referenced a little bit of this in her remarks just a while ago, is that the amount of data we have at CMS is truly amazing. But the problem is that we don't have it in a very good way to sort of leverage it the way we need to. And on opioids in particular, the more that we can use payment data and treatment data and patient information all together to really be able to see where there are problems and how we can leverage them, that's going to be critical to trying to figure out how we're going to be able to move forward. So in the buckets of prevention, treatment, and data, that's where we're really going to be focused moving forward and see how it is that we can build in some measures, maybe not meaningful measures, but different kinds of measures that will help us to be able to determine how we're making a difference as a payer in the opioid epidemic. So some of the things that we've been focused on and some of the issues that we have really been thinking about in the opioid epidemic is how it is that we can really use what we're doing at CMS to help drive progress in the opioid way. So we've had a number of ways that we've been doing that. Some of that has been, as the administrator mentioned, through some of our payment regulations. Some of it has been through things like our call letters or the new guidance that we're issuing to the C&D plans. One of the biggest things that we've done in the past couple of weeks is issue new guidance in the call letter that just went out a week ago that says that there will be more flexibility given to putting in hard edits for the Part D plans so that they can be able to put in harder sort of stopgaps to make it so that they can't prescribe for more than 7 days, and they can put a limit to the amount of what can be prescribed within the 7 days. That's a huge step forward, something that we heard a lot about during the listening sessions last fall, and is something that we're very committed to trying to pursue as we work with the plans to sort of respond to the call letter. We're also very interested in working to see how it is that we can work with plans to see what they can do on the front lines, the Part C plans and the Part D plans, to be able to put sort of compliance programs or opioid deterrent programs in place, if you will, to be able to do within their networks a better job of policing sort of the prescribing patterns and finding overprescribers and overutilizers, and then taking action against them. Other types of things that we've been looking at across the board are how it is that we can, work to sort of put things in on the front end to stop people from becoming addicted. Through the Part C and D plans, some of the efforts that they've done over the past 4 to 5 years have resulted in as much of a 70% reduction in first-time opioid addiction beneficiaries. So they've really been able to stop the number of people who are on opioids, getting opioids, and then potentially getting addicted to them. We've been able to use our data, such as the data that we get from our Office of Data, OEDA, to be able to put out a heat map that is online at the CMS website, where you can actually see down to the zip code and county level what the prescribing patterns are in that particular area, and using that information to really help to be able to target interventions so that we can have it so that not as many prescriptions for those types of drugs go out in those areas, and that we look at alternative treatments, alternative ways of working to make sure people in those high saturation areas are hopefully not being as impacted. We've had a number of other things that we've continued to do across the board in terms of helping to look at where it is that we can partner not only within CMS but externally as well. And hold on, let me just get to the right slide on that one. I think I went ahead a little bit. Sorry, the glare is bad up here. So anyway, but one of the things that we have done really well is to work across HHS. And I think one of the things that we're going to be doing going forward here in 2018 is to really leverage those external partnerships within the HHS family. So I'll give you a couple of good examples of that. CCSQ has already been working very closely with the Centers for Disease Control to really look at the prescribing guidelines and the types of information that CDC has been putting out, and determining how it is that they can take that information and integrate it into things like conditions of participation. We've also been looking at how we can integrate some of those CDC guidelines into the payment rules, and really try and work with them to try and figure out a better way to sort of make sure that we're collaborating collaborating and sharing information as much as possible. A lot of the public health data that they get is really relevant to us, and if we can use our claims or patient data to put with that public health data, it gives us all collectively a better picture of what's going on and where some of the problems are. I had the opportunity to go actually down to CDC about 2 weeks ago and was in Atlanta meeting with a number of the folks there. And one of the things that we talked about that I think is going to be an exciting potential was the fact that there is a lot of good outreach and education that can happen with respect to the opioid epidemic. They've been working on a number of prescriber and provider focused educational materials that we can hopefully help them with at CMS in terms of spreading the word to our provider network about those programs that they've already developed, and then using those to help better educate people about alternative ways to approach the opioid epidemic, but also other ways to sort of help in terms of raising beneficiary awareness so that people know the things to look for if they're prescribed opioids, and if you have somebody who's new to opioids, some of the potential signals for addiction that they should be able to be more aware of. Similarly, we've been working with SAMHSA on a lot of their issues that they have in terms of trying to figure out how to do a better job of sort of partnering to find out better ways to share information so that, for instance, if someone presents to the emergency room, it's possible to get their records so that you can tell whether or not that person has an addiction in the past. Right now, one of the challenges is often people present to the emergency room, they don't have that information, and it results in them getting prescribed opioids when in reality they shouldn't. So we've been talking to SAMHSA about some of the barriers that exist to sort of help make it so that that'll be easier for a better communication of information. And then we've also been working with the National Institutes for Health. Again, CCSQ has been leading the charge on this, but looking at what are the clinical trials that NIH has underway and how we can tie them to some of our coverage criteria and how it is that we can sort of partner together to think about this more globally and holistically. So I think at the end of the day, some of the sort of goals for this year are to figure out how we can use the prevention, treatment, and data categories to help us to really be able to show a demonstrable impact on Medicare, Medicaid, and exchange beneficiaries. How is it that we can show that the number of people who are addicted to opioids is dropping because of some of our educational interventions, because of the edits that we're putting in place to sort of limit the amount of opioids that they might be able to get, and how is it that we can leverage our resources not only internal to CMS across all of the CMS components, but also externally within HHS to sort of leverage each of the unique perspectives that our partners have, and then further beyond that, working with the outside community to really be able to learn from each other. I mentioned the roundtables that we had last fall. One of the biggest takeaways from the roundtables last fall was the fact that everybody to an entity that participated in them was so grateful that we convened the roundtables because they said it was the first time in each instance that someone had brought them all together to really be able to share information and talk about lessons learned and what it was that they were each doing. It really struck home to me when we met with the various plans, how many of them said, we really are so appreciative that you all convened this gathering because we as the plans really haven't had the chance to get together and to have a forum where we can talk about what each other is doing, what's working, what's not working, and to be able to think about that and share those lessons learned. The same thing happened when we had the various supply chain entities, the states, and the providers. But it really was a kind of an aha moment, the fact that we really do need to be having more opportunities both within CMS, within HHS, and then with the industry as a whole to really be able to share those lessons learned and to be able to work together so that we can sort of learn from each other about what are the best approaches. The administrator really, sort of highlighted this when she said that we all need to work together on these types of issues. And I think opioids is a true example of where it's going to take that kind of collaborative, multi-pronged, multifaceted approach to really be able to make a difference. And we're hopeful that with the activities that CMS is engaged in, with the help of partners like all of you, that we're going to really begin to see a real difference. So with that, I thank you for having me to fill in today, and I look forward to the panel with the rest of the team here in a minute. Thank you. Okay, thank you. Right here.
Let's give her one more round of applause, please. So, Good morning again, everyone, and thank you all for being here. I'd like to just take one quick second and ask for you to turn to the person next to you and just share what's the most exciting thing that you've heard from Ms. Brandt thus far and about our work around opioids. We're going to take just a few minutes to do that. So ready, set, we're going to come back in maybe 3 minutes.
I talked too fast, sorry.
This is excellent.
We'll do this instead.
Whoa. Hi, I'm Kim Brandt. Nice to meet you. We just met her, yeah. Hi.
Because otherwise it would be just a quiet murmur, but it's going to be hard to get.
I know. Oh, did you? Yeah. There's nowhere else. Yeah, I got one of the last spots on the very top. Yeah.
If I could bring the full group back together, please.
It's going to be hard.
Thank you very much, everyone. All right, we're going to hear from a few individuals in the room. Excellent. Can I just see where the microphones are? All right. If you heard something very powerful from the person with you, if you wouldn't mind raising your hand, we're going to get to hear from about 3 or so individuals, some highlights on what they heard. We have a mic on this side, we have one coming to the left, and we'll have one in the back. All right, I'm looking for volunteers. And if you wouldn't mind standing and sharing your name and your network as you share your comment, please. Do we have someone else that's waiting that we can give another microphone to, please? I see someone in a green there. Others on the left side. Thank you so much, Nicole. Good day, ma'am.
Hi there. Thank you for this opportunity. I'm Christine LaRocca with Telegen, Medical Director, and we were discussing how complex the opioid epidemic is and how the approaches will differ upon whether they're new starts, which is almost easier to get your hands around, of not getting 30 days after a wisdom tooth or something like that, versus the chronically addicted and the approaches that are necessary there. As a physician, I can say there's some concern that a just say no approach is leading people towards heroin and deaths associated with that. So it's just such a complicated issue, and the approaches will differ greatly depending on the population. So there's a lot that we can do around new starts, clearly. I'll put in a plug that I wish we were able to work more with dental practices, and I know that that's,
So that's another big one.
Excuse me? Oh, okay. And but with the chronically addicted, we have to figure out approach of how to get people affordable addiction treatment, and 30 days is way too short.
Hi, I'm Paul Mulhausen. I'm also from Telegen, surprisingly, their Chief Medical Officer and one of our Quality Innovation Network medical directors. I'm quite intrigued by the work that CMS is doing with both Part C and Part D programs, and quite excited to see how that may play out. In our conversation, we talked primarily about two issues. One, the role of the clinical pharmacist in terms of their potential impact on the opioid epidemic, and then the larger issue around reducing the supply of opioids in the community.
Excellent.
Once they've been prescribed, now they're in the reservoir of opioids. How do we reduce and eliminate that excess supply that gets diverted?
Thank you very much. Can I have one last comment or reaction of what they heard or discussed with their colleague?
Oh, there. I just have to eat the mic. That's the thing. Hi, I'm David Nilicina. I'm with CMS. I guess that's my network. So what we talked a little bit about is excited about the possibility of data that we have at CMS to explore this. I mean, we have such rich data sources, and one of the things that I think would be useful is to combine not only the data we have on the prescriptions, but trying to link that to the clinical conditions associated with those, and also the practitioner types associated with those, to try to sort of identify a subset of those prescriptions that are clearly suspect in terms of their appropriateness versus those that are clearly appropriate, and use that to sort of fine-tune our approaches to outreach.
Excellent. Thank you very much. Thank you very much. And thank you all for being engaged in that dialogue briefly. And what we heard was a little bit about asking about the continuity of care and the expanded care team. We talked a little bit about the actual availability of medication. Also the process in terms of how do we take the information, utilize the data, and utilize that data to affect the change moving forward. So thank you all for your interaction during that time. Today's a very exciting day. We really appreciate the comments from you, Kim, and we look forward to hearing from our panel. We have Dr. Kate Goodrich, our center director. We also have Janine Awugo, our deputy group director from QUIG, and also Dr. Paul McGann, our chief medical officer from the Quality Improvement and Innovation Group. Now, the other ladies that I have on the panel with us right now are Dr. Zandra Glenn, who's a clinical pharmacist and spent the last 7 years working in maximizing clinical pharmacy services and patient safety with a large number of networks across the nation. And then also Dr. Sarah Chenard, who has been working in a rural area in the state of West Virginia and has worked not only within her practice, but also with her state and also with federal entities. So you're going to be hearing a lot from them. You're also going to be hearing examples from our networks. So as we get started, our intent is to profile strategies and results of the high-performing organizations, and also to ensure that we are able to showcase the medication management and opioid initiative in terms of its future strategy and what has been accomplished to date thus far. Our intent is to hear and acknowledge and hear from the CMS officials those strategies for spread that are working and the things that should be prioritized by our networks and the leaders present in today's session. Now, as we think about all of these pieces, our intent is really to put everybody in this room in action. You heard Dennis talk a little bit about making commitments and living up to those commitments and delivering on those commitments. Part of what we will do today is to seek commitments from each and every one of you. Commitments and action. As we're thinking about how we do things differently, and I shared with you that we're part of the team in the Quality Improvement and Innovation Group within CCSQ. So we do things and we test things. So I'm going to ask you to take out your cell phone. Yeah. All right, if we could do that quickly, please. And if you could send a text to the following number, 22333. And in the message of that text, if you could put...
We're okay.
Man down. QC 2018, Quality Conference 2018, QC 2018. And if you could go ahead and do that now, and you're going to get a text message saying that you've joined the session. All right, and then you can put your cell phones down until we get back to the time where we're going to get some interaction and feedback from the actual team. So you're going to hear now from several networks that are going to share their action and results on opioid management. And when we think about the networks, we think about who are these improvement networks. And the improvement networks are multiple. They have several different forms. I'm going to highlight just a few of them. The first one is the QIOs. They are impacting community settings by improving naloxone access and education, supporting first responders and other strategies that they found to be successful. They're impacting community pharmacies with surveillance programs for PDMP, medication counseling and treatment agreements. They're also working with nursing homes and developing treatment, referrals, and risk assessment tools. We are very happy to have them as a part in the foundation of our network. So all the QIOs, if we could see a wave of hands here, welcome. Excellent. Thank you so much. We're also going to hear from the TCPI network. Now, TCPI network is using treatment agreements with both primary care and specialty care providers. When TCP started and our intent was to bring in 140,000 clinicians, everyone thought that it was going to be primary care. What we ended up with is 70% specialists. This is an important variable. It's one of the only models that has a focus and has so many clinicians that are specialists as a part of its work. Now the HINs, the Hospital Improvement and Innovation Networks, you're going to hear a little bit about our stories across these networks, but the HINs are working with hospital systems prescribing changes and overdose monitoring. Now, as you see this graphic, I want to make sure that we go back to where we started, which is that the patient is at the center of each and everything that we do. And it's these networks keeping the patient at the center, which is going to facilitate a catalyst for us moving forward. We're improving the lives of patients who are receiving opioid medication regardless of where they are within the healthcare system, and we're seeking partners that will enable us to do that at to a greater extent and much faster. Now, Ms. Brandt shared about a number of the different things that are happening at CMS. We have a number of different things that are happening within our own networks. One of them is the CMS campaign for meds management, and its leader, Dr. Anita Thomas and her team have spearheaded this work. We are looking in this work to not only interact with healthcare professions, but also including patients in the approach to opioid management. The campaign emphasizes the voice of the patient in their healthcare. And this program is designed to improve medication use and management, especially in the 3 high-risk medication areas, of course being opioids, anticoagulants, and diabetic drugs. Please take a chance, the opportunity to view the website and see additional information about how this program is working and how they're supporting and helping advance patient-centered shared decision-making, especially for the high-risk medications, including opioids. Now, another piece of work that we have started and really made quite a bit of headway, I would say, is the Medication Management and Opioid Initiative. We started this initiative in June of 2017, and our goal is to generate results in reducing opioid misuse and effective medication management. We have multiple pieces of the plan, but the 2 main pieces are to highlight the urgency and mobilize the networks into action to address the opioid crisis. That's point number 1. The second one is to really focus on opioid management and medication. Now, thinking about these two priorities, we know that in this area, our focus is on opioids, anticoagulants, and hypoglycemic agents, very similar to Campaign for Meds Management. But in terms of our work and how we are moving forward, our intent is for both to be a part of one. We're one CMS, one QUIG. We are working to maximize the value of our work across our networks and to take those best practices and spread those. All right. This is a photo of our team as we launched the Medication Management and Opioid Initiative in June, and what I would love to just share as we're moving into our next speaker is that there is room for all of your ideas, and there's room for action. We encourage and request for you all to be a part with us in this action moving forward. We're now going to hear from our national faculty co-chairs who are going to share a little bit more about the actual campaign and initiative, and then we're going to hear the examples from the individuals at the actual network. So to get us started, let me turn the mic over now to Dr. Zandra Glenn. Zandra?
All right, good morning to all of you. My name is Zandra Glenn, and as Fred mentioned, I'm one of the TCPI faculty members, and I wanted to talk to you all a little bit about the campaign that Fred just spoke about. It's called the Medication Management and Opioid Initiative, and I wanted to give you all a little bit of information about this. As a part of this campaign, we have created a pledge, and we're calling it the MMO Pledge. Some of you may have heard of it. And part of the reason why we created this pledge is because we wanted clinicians and all other healthcare providers that are part of all of the CMS networks to make a commitment to help us reduce the opioid misuse and abuse crisis that we're currently seeing within the United States. Now, we've created this pledge, and there are 4 parts of this pledge, and we're asking clinicians, we're asking all of the quality improvement networks to sign this pledge and to get all of the clinicians that are part of your network to be a part of this body of work that we're doing. Now, a lot of people are afraid to sign this pledge. It's amazing when we see the questions coming in. What is CMS going to do with this pledge? Are they coming to get our firstborn kid? What do we have to do? And we don't want a firstborn. We don't even want blood. What we want is commitment, okay? We want commitment, and we want you to be in action on helping to reduce the opioid crisis. There are 4 parts to this pledge, and they're up on the screen, and I'll briefly describe them. The first part is that we want you all to be educated and to be informed about what it is that you need to do to get your patients the appropriate care for opioid management. So our goal is to make sure that you are informed and you know what it is that your patients need to get them the appropriate management of opioids when they are in need of those medications. So it's important that you know what to do. So the commitment is, I'm going to educate myself and my teams, and I'm going to commit to this body of work. The second body of work is that we want you all to focus on person and family engagement. We want to ensure that the care that the patients that you have on opioids are receiving patient-centered care. It's individualized for their needs, their specific needs. One shoe does not fit everybody. So the care that those individuals may need might be quite different. So we want to make sure that the work that you all are doing for around opioid management is individualized for your patients. The third part is we want you to leverage work that's already being done. I don't want y'all to go out and create the wheel, all right? There's a lot of things that are already being done in your state. There are a lot of things that are being done in your regions, in local areas, specific to opioid management. Find out what's happening in your states. Find out what's happening in your regions. You must know what those programs are. And enroll the clinicians that are a part of your networks into that body of work that's already being done. Get them involved. Get them using the metrics that are already in place for your state and for your region. So you don't have to go out and create anything new. Just join the effort of what's already being done and really drive the impact of that program. And then last but not least, we want to spread our successes. There's a phrase that we use in almost every body of work that we use, and we call it steal shamelessly, okay? We're not afraid to steal the good works that you all are doing. And our job is to spread those across all the networks. So if you're doing something really unique and exciting, let us know, because there may be other people in similar situations that could definitely learn from what it is that you're doing, and you can learn from them. So one mantra that we always have is the answers are in the room. We all have a little bit of the answer, and if we all bring it together, we could really solve a lot of the problems across a lot of the networks. So these are the 4 parts of the pledge, and we're asking you to please support it. Get your clinicians to support this and sign and be a part of our pledge with us. To this date, we have over 11,000 clinicians that have signed that pledge, and I'm really excited about that number. Very good. Thank you. We want to see this number grow tenfold. The next time we come up here, we want to talk about the 100,000 clinicians that have adopted this commitment to help avoid opioid misuse and abuse within their communities. Our intent is to spread this. As Fred mentioned, this began within the TCPI community, but our intent is to spread this across all of the networks and have all the networks committed to being a part of this body of work and signing our pledge. All right, here are our next steps. All right, we've launched this, we've introduced the pledge to everybody. We want to establish the business case for medication management. We want to ensure that as you all are implementing opioid-specific programs and working to work on diabetic medications appropriately and anticoagulants appropriately, we want to make sure that your programs are sustainable, all right, and that we have a business case and a model that can be spread across all of the TCPI networks. We want to improve the IT technology, so we want to ensure interoperability as we work to incorporate that into our medication management programs. We also want to develop a medication management change package. I'm really excited about the body of work that we plan to have this, and we plan to do all of this by August of this year. So that means that there's a sense of urgency, and we need all of you involved with this. Within the change package that we plan to establish, we need support and we need input from every single network to help us develop this change package. And we want to ensure that all of the good work that's being done is included as that part of that body. And then we also want to maximize public and private partnerships and also academic institutions. We have learned from doing a lot of this work with a lot of different quality improvement organizations that those academic institutions can really help support the work that we're doing. Did I move that? I apologize. All right. We want to include schools of pharmacy and schools of medicine and schools of nursing. So we plan to engage them and help them to be a part of this work. So right now, what I'm about to do is introduce Dr. Chenard. Dr. Chenard is another one of our faculty members from the TCPI network. And she is from a community health center in West Virginia who has done extraordinarily good work and have been very successful in implementing a pain management program. Please listen to the strategies that she's going to share with you today and think, what can I steal from Sarah and take back home to incorporate within our network? Sarah. Thank you. Well done. Thank you.
Thank you so much for having me. There is little that I am passionate about more than fighting this problem. You can see from this slide where we are practicing in Central West Virginia, and we have been described as ground zero for the opioid epidemic. And so what happened is I was serving and still serve as medical director for this group of health centers. And in 2010, so a long time ago now, I approached our CEO and I said, our clinicians are beyond burdened. They've had it. They don't know what to do with this issue. This battle with patients, and it was a battle with patients about chronic pain and about opioids, is really sucking the life out of our clinicians. In addition, our patients are miserable. Patients are being overprescribed. Patients are being underprescribed. And so really no one was happy. And so it was time to get in action. And so we spent about 2 years fumbling around trying to figure out what to do, and then eventually in 2012 launched what has been a really successful program that I want to tell you a little bit about. But before I move on to the next slide, notice here that we have 15 health centers, a dental clinic, etc., but that we carve out both behavioral health and pain management as special programs. So I mentioned that in 2010, the providers and the patients were all coming to me saying that they were unhappy about what was the beginning of the pill epidemic. And you can see that by 2016, the data supports that West Virginia had a real problem. Unfortunately, we remain #1 in drug overdose deaths as a state. So what did we do? What we did ultimately ended up looking a lot like the checklist that the CDC developed in 2016 for primary care physicians who fight pain. And so what we did was really not a lot of rocket science, and it's something that you can steal very easily, which is we came up with a plan and we stuck with it. And the plan largely involved setting expectations for patients in the beginning. We made it very clear that we were going to be in a partnership, that we as the clinicians were going to do our part, but that we also needed the patients to do their part. Someone mentioned in an earlier session the fact that a lot of patients can be treated without opioids. That in years past, we would sort of start with opioids for pain that could have been managed with much less than an opioid prescription. And then in this room, someone also mentioned the fact that we have a lot of people who are afraid to write opioids altogether. And so what we wanted to do is create a plan that was that medium porridge for servicing both the patients who are in need, but also avoid the clinicians who are really afraid of getting into that being labeled as an overprescriber. So what we did is we began with education, and we said, what we need you to do before anything is commit to engaging in what's going to be a very long relationship in and around these opioid prescriptions. And so we explained to them, what is a contract? How do a clinician and a patient end up in a contract to partner over something like a prescription? That's new territory for patients, right? They're diabetic drugs, they're high blood pressure drugs. I mean, there was never need for such a thing before. And so that contract has a lot of information in it. And we use that information to explain to them what the risks are. I confess, when I was writing opioid prescriptions years ago, I never began with a description of how we were going to try to stop the medication, right? So stopping the medication is now an early part of that conversation. In addition, we set realistic expectations about pain. Life is not pain-free. And so really starting with a really interesting project that came out of the DoD that was about setting expectations for improving quality of life, not living a life that had zero pain. So all of these steps really come into play when we begin introducing the idea that maybe opioids are going to be part of your future with a patient. And then we created what we call a specialty clinic. But this specialty clinic resides right within our own FQHC in rural West Virginia. Those patients go first to our behavioral health program and have really a psychiatric assessment, not because we think there's anything wrong with them, but because we want to understand what are their social determinants of health. Are they able to get to visits? Can they comply with random urinary drug screens? Can they show up for pill counts that are unannounced? Can they do the things that we think are important to be a participant in this program? Because if they can't participate in those things, we know they're doomed to fail from the very beginning. So putting these strategies together, screening them for all of the areas of their life that are influenced by their pain is really where our success stemmed from. And so people get into a very deep relationship with their opioid prescriptions, but they also get really deeply entangled in pain. And so just turning a blind eye and saying, we're not going to write prescriptions wasn't the right decision for us, but nor was it just to blindly wander in and just keep writing prescriptions. So I'm going to move on to this next slide. This is what we're pretty proud of. The program, like I said, we spent 2 years trying to figure out what to do, and by 2012, we really had what was a reliable process that we used to treat every patient who came through our clinic. Almost 2,700 people have been treated through our program. We currently have 1,057 patients, and we have had 0 overdose deaths. And so let me talk a little bit about the work outside of the walls of our clinic. One day a week, I work at our state health insurance agency and serve as their medical director. And we worked in collaboration with West Virginia University and came up with something that's called the SEMP, the Safe and Effective Management for Pain Pills. And what we did is, it was simply an education program. They're clinical pharmacists at the university who we identified at the insurance agency, and we were able to see who are the clinicians who are writing the highest number of these prescriptions. We asked the clinical pharmacists to get in touch with those docs and do a simple education about morphine milligram equivalents. The CDC guidelines describe over 50 MMEs as being dangerous and over 90 being really in the most extreme of circumstances. And so you can see here there were 414 patients who were receiving high doses of opioids over the 50 MME amount. And just through conversations between the clinical pharmacist and the prescribing physician, 70% are now receiving less than 50 MME. Of the 125 patients who are still over that level, you have to remember that now at least their clinicians have been educated and are aware of what that cutoff point is and that those patients are in that high-risk category. So I want to end with this. Where could we go from here? Now that we have this program in place, what we see as being important is helping people with recovery. And so while within the walls of our FQHC we can't come up with full recovery programs, we are launching an abstinence-based Vivitrol program for our patients who suffer from addiction. We're also leveraging resources in the community such as Alcoholics Anonymous, Narcotics Anonymous, et cetera. I already mentioned that we're working with the university. They've launched a pain center that is non-opioid based. It's only alternative therapies. And so we have patients that we can refer to them locally. We have behavioral health to help patients who are unable to keep up because their lives are unmanageable and see if they can maybe re-enter the program after intensive behavioral health services. And then we'd really like to get into the space of vocational rehab because, as you know, this illness comes in, wreaks havoc, and then can really make it almost impossible for people to get their lives back. So thank you so much for having me, and I look forward to the rest of this meeting.
Thank you very much, Dr. Glenn and Dr. Chenard. I'm going to ask you to take your phones out again, and I'm going to ask you to please send us a response to the following question. How will you be in action to improve opioid management? If you wouldn't mind sharing your response at this time, we have a team that's going to close the poll in approximately 3 minutes or 2 minutes. Maybe even sooner. All right. As you're thinking about your response and sharing that, I am also going to begin to turn to our panel and see about their reactions. And we're going to ask to hear from Ms. Kim first, and then we'll go to you, Kate, and then we will move to Dr. McGann and to Jean. So, Kim, if you wouldn't mind sharing any thoughts that you might have, we would greatly appreciate it, ma'am.
Well, first of all, I just want to say I was so inspired by both of the speakers just now. There's so much good work going on. And I'm sorry, I'm echoing. Anyway, I thought I knew a lot about what was going on at CMS, but some of the things that you all are doing is just wonderful. And so thank you for the work that you're doing. I think, my #1 goal is to get us to be able to have a real action plan at CMS that is cross-agency that really can start to show a difference. It's going to be difficult because we've got a lot of good individual actions, but we don't really have a coordinated approach yet. But I think my goal is to kind of bring the same energy and enthusiasm that both of our previous speakers did to our CMS efforts and really try to point us in a better direction.
Thank you, ma'am. Kate?
So as happens so often at this conference, when I hear stories like this and when we are talking about a difficult topic, I listen to these stories and I think about the issue at hand in many ways more as Kate the hospitalist, not Kate the CMSer. And so that is true today. So I still practice at GW Hospital in Washington, D.C. I've been there for many years, and I was 13 years in full-time clinical practice before coming to the federal government. And this was an issue that absolutely vexed me and all of my fellow clinicians, doctors and nurses alike. And what ends up happening is that, well, first of all, internists like myself and most clinicians, I would argue, are very poorly trained to deal with pain. Really poorly trained, right? There are specialists out there who do it very well, but for the majority of us, we don't really know how to do that. And so confronting this crisis is completely overwhelming to us. And most people take one of two avenues. I'm generalizing greatly. But we either give up and we just keep doing what we're doing, or we just say no. And I've seen both happen in practice. And of course, clinicians were told for years that these medications were not addictive. And now we feel like it's a big bait and switch. And we just don't know how to deal with it. And the other thing that happens, and if we're really honest with ourselves in this room, we know what can happen in this circumstance, which is that sometimes we end up blaming the patient. And I think we have to all acknowledge that does happen, and that's very hard for us as clinicians. And so the piece of what I just heard that really actually leapt out at me the most is one of the things in the pledge. And that was around patients with opioid use disorder being treated with respect and in a person-centered manner. Because all too often, while there are many of us who try very hard to do that, sometimes we're so overwhelmed that we don't do that as well as we could as clinicians. So what I would like to challenge our networks to do is, as you are discovering local innovations like what we just heard in West Virginia, and starting to investigate those, look at the data, spread those best practices, think very hard and front and center about how we can work with our frontline providers to ensure that we maintain that respect for all patients and we approach this in a patient-centered manner.
Excellent. Thank you very much, Kim, and thank you, Kate. We are going to turn to Katie Brown, and we will then come to you, Janine, and Dr. McGann after we hear from these two individuals. One, Katie Brown is, once again, a PharmD, and she's a program manager lead from Telligen. We're going to hear a little bit about their work. And Katie, if you wouldn't mind.
Thank you very much, and I feel very honored to be here today. I didn't bring any family pictures. Yes. But I do feel inspired to tell you that I have two young boys at home that have a lifetime yet to be impacted by this opioid epidemic, and that's why I'm here today and doing this work. So we've all heard the numbers. In 10 years' time, opioid-related emergency department visits have increased 99%. And in just 3 years ago, we prescribed enough opioids to supply all Americans around-the-clock opioids for 3 whole weeks. And that's equivalent to over 200 tons of morphine. And more importantly, by the time we leave here Wednesday afternoon, we will have lost 270 more loved ones to the opioid epidemic. It may have taken us decades to get here, but change can start today. So one idea, one small team, and one step in a new direction is what I'd like to share with you today. So I'll start with one idea. In January of 2016, the Colorado Hospital Association asked their constituents what kept them up at night. And what they learned was that opioid safety in the emergency department was a huge concern. So armed with this information and a desire to help their team, CHA set out and formed the Opioid Steering Committee, and that's where the Telligen QuinnQAO comes in. Strategic partnerships formed between CHA, which is the HRET HIN state partner, and the Telligen QuinnQAO, the Colorado Consortium for Prescription Drug Abuse Prevention, the local emergency physicians chapter, and the Emergency Nurses Association. Together we formed the Opioid Safety Collaborative, and we set out to improve opioid safety in Colorado emergency departments, one small team. By summer of 2017, Colorado ASAP published new ED opioid prescribing and treatment guidelines. And what's unique about these is they're some of the first guidelines to call for broad adoption of alternative to opioids, which we call ALTOs, but also include harm reduction principles for patients who use IV drugs. The guidelines have 4 pillars, and we decided to focus on pillar number 2 for our opioid safety pilot, which is using alternatives to opioids for the treatment of pain, one step in a new direction. Our goal was to reduce administration of opioids by ED clinicians using these new guidelines by 15%. And as you can see here, every one of the 10 participating emergency departments surpassed that goal and collectively achieved a 36% reduction in opioid use in the ED. The pilot cohort also increased use of ALTOs, or alternatives to opioids, by 31%. And don't worry, we haven't forgotten about the 5% in between the opioid and ALTO use. We're still analyzing the HCAP scores to see what impact this change has had on pain outcomes and patient perception. Telligent QuinnQIO also contributed by analyzing claims data for information such as opioid-related adverse drug events, readmission rates, and naloxone access. There are 7 Quinn measures in progress, and we hope to use these outcomes and information to inform future work in this area. But the 7th Quinn metric is perhaps the most intriguing. We looked at patients who visited the emergency department because of an opioid-related adverse drug event, and then who left the ED and filled another opioid prescription. What we found is that the pilot cohort is improving at a much faster rate than the state in general, indicating a shift in prescribing habits. And as they say, the rest is history. We had hands-on training, site visits, staff champions, etc., and I'm oversimplifying the amount of work and commitment that it took to make this successful. But what I'd like to leave you with is this. I hope that everyone leaves this week feeling empowered to activate one idea, one small team, and take one step in a new direction. Thank you.
Thank you so much, Katie. We're going to hear from Stephen, and then we'll go to Paul and Janine. And welcome, Stephen, from the Carolinas Health System. Thank you so much.
Good afternoon.
Thanks for coming.
I'm the Medication Safety Officer for Carolinas Healthcare System, and anytime I talk with a group like this, I like to give you a picture of where we are. We're in North and South Carolina. We have a mix of hospitals. 30 of them are a part of a hospital improvement innovation network, so we're both a system and a hen. This also will be a reflection of how fast healthcare is changing. I turned this slide in last week, and now our name is Atrium Healthcare, and we're moving into Georgia. But what we're here to talk about is the opioid epidemic and some of the work that we've been doing. We started this work with the hen back in 2013. We've got 30 hospitals that are part of that. You can see our baseline, you can see where our numbers are. We're below our baseline. We don't know that 0 naloxone reversals is the right place to be, but that's our goal. That's where we want to be. Every hospital has improved, but every hospital has an opportunity to improve more. What I like to say about this slide, though, is it's 700 patients that were not impacted by getting too much opioids while they were in one of our hospitals. That's a much better number than a rate, and it helps us focus back on the patient. Awesome. I just wanted to share a few things. I'm not going to read through all these slides. You'll get them so that you can look at them later. But the big thing that we noticed is just focusing on these numbers, reviewing every time we use naloxone to look for why we used it, allows us to come up with an opportunity every day to look for improvement. We also have collaboration, not just in our network, but across all of the HENs. That's what the HEN is about, sharing those best practices, learning from one another, and stealing shamelessly, as we heard earlier. We look at MME as well, and MME has allowed us to move on to some of our future work, which is really changing culture. And changing culture is getting into that prescribing practices. We're looking at a dashboard for physicians. We're looking at ways that we can share those information back to those prescribers so that they know where they are, so that we can focus on prescribing for the patients that need the drugs and not using the opioids in places we shouldn't. And we also are going to try and engage our providers in the MMO pledge now that we've learned about that. We think that's a great opportunity to continue to engage them, because this doesn't work if our providers are not engaged. Thank you.
Excellent. Thank you very much. We're going to go immediately to Janine. Janine, what did you hear that resounded with you? We did close the other poll. There is a poll or an opportunity for you to respond now. If you'd like to respond to this question, we'd appreciate it. But Janine, if you wouldn't mind sharing with us what you heard or what was most exciting to you, please, ma'am.
Sure, Fred. So one of the best things that I heard was that all of the interventions that were mentioned were based and grounded in data. So what you heard from these clinicians was that they know their patient population, they analyzed the data, and they came up with methods and initiatives that work best for them, which is exactly what we want you to do. We want you to steal shamelessly from others who have examples that you think will work for your populations, and then strive to partner with patients, educate them, make sure that they feel respected. But we're talking a lot about getting the clinician commitment. We also want to strive to get patient commitment, because we need to take an approach that comes at this from both angles. And I love these examples because all of them have done that and have had tremendous success and great outcomes for the patients that they serve. Thank you so much.
Thank you, Janine. Dr. McGann?
You know, this is one of the best presentations I've heard, and just like Kim, hearing all four of these presentations filled me with hope. That's what I felt as I heard each of these conversations. And the other thing I was impressed with is how surprisingly simple these interventions are. I think someone said, this isn't rocket science. This is just educating yourself about these drugs, educating yourself about the dangers, and then complying with evidence-based guidelines. So it's in the reach of everyone in this room. And that leads me to my final point, which is this is what quality improvement is all about. This is what this conference is all about. The answer to these seemingly overwhelming problems, when you listen to the news, is overwhelming, but the answer is in this room. Look around you. There's 2,600 people. Here in the front row, look behind you. Look at how many people there are. If you're in the back, look to the left and look to the right. You've got many more answers where this came from right here in this conference. I'm so glad this happened on the first day, because you can go and find even more innovative solutions to this problem over the next 3 days. It won't work, though, unless you make a commitment when you leave here to implement these things where you are. They're simple, they're easy, and they're effective. Please be in action with commitments before you leave. Thank you.
Thank you so much, Dr. McGann. Greatly appreciate your feedback. Thank you for the interaction. I would just like to close with Ms. Kim, if you'd like to have any last statement that you wanted to make, ma'am.
No, I would just reiterate what Dr. McGann just said. I think this is an awesome opportunity for you all. I was very inspired by what I heard this morning. I look forward to hearing more about what the breakout sessions are and what you all learn from each other. And just go out and have a great conference.
Thank you. Thank you to the panel.
Thanks again. You were wonderful. Thank you so much.
Ladies and gentlemen, that concludes our session for today. Thank you for coming, and have a great afternoon.